So thank you, Pooja, for having me, and it's really nice seeing all of you here. So I'll, in line with the name of the IC called X files in surgery, I'll be sharing the case called the unusual suspect. So I hope my slides are visible. Okay. So the crime scene here was that of a 24-year-old male who had presented with redness and blurring of vision in the right eye since just about 3 weeks. There was no history of use of any medication, any trauma, or any chemical injury. There's no relevant systemic history here as well. On examining the patient, you can see the vision is just about 1/60. And when you look at the conjunctiva, there's extensive symblifera formation here, very acutely inflamed eye, severe congestion, symblifera nasally as well as temporally. And the other eye, of course, here was absolutely normal. When you look at the cornea in the right eye, you see this large epithelial defect about 6 millimeters by 4 millimeters. And the surrounding epithelium is also extremely unhealthy. It's heaped up, irregular, so an extremely inflamed ocular surface. There was no infiltrate here. So I went ahead and treated the patient with a bandage contact lens, topical steroids, and antibiotics. And since the patient was from UP, where trachoma is also endemic, though this case did not typically look like that, I also gave a course of oral azithromycin. So 10 days later, surprisingly, the inflammation was completely gone. The epithelial defect had resolved completely, but there was absolutely no improvement in vision. I was, however, now able to visualize the fundus, also because the patient was cooperative and the view for me was clear. And I saw that there was significant optic disc pallor here temporally. And I mean, the patient was absolutely sure that the visual impairment was not from before. And I also saw some examination sheets which revealed that his visual acuity was normal about a month before these episodes had started. So it was quite evident that this visual impairment did happen at the same time as the cicatrizing conjunctivitis that developed. The other investigations that I went for were all normal. So really none of our usual differential diagnosis of acute or even chronic cicatrizing conjunctivitis fit in here. So I went ahead, looked up in literature, and I found this entity called Mycoplasma pneumoniae conjunctivitis. So, and surprisingly, this is a lot more common than we know of. And it is also associated with optic disc anomalies like papillitis and optic atrophy in various cases. So this has been reported, but there is not too much literature on it. There are various case series, some case reports, and there's one study which had looked at patients who were suspected to be chlamydia conjunctivitis. They were sent for serology, and a significant proportion of them were actually found to be Mycoplasma pneumoniae conjunctivitis. So they concluded saying that, this is a frequent and undetected cause of acute and chronic conjunctivitis and is often associated with other anomalies such as the optic disc anomalies and uveitis as well in some cases. So I went ahead and did serology for Mycoplasma pneumoniae in this particular patient. And surprisingly, for me at that point of time, it came out to be positive. So both IgM and IgG were positive in this case, which has about a 95% sensitivity and an 85% specificity. So my takeaway here is that Mycoplasma should be considered as a suspect when we see acute conjunctivitis, particularly this kind of a picture where you have extensive symblifera and when it's associated with optic disc anomalies. I could have done a conjunctival swab and done a PCR, which would have been more definitive, but PCR for this is actually not very easily available. So even if I had suspected it at the time of the acute infection and gone and tried to do a PCR, I might not have been able to do it. So what this case taught me is that I'd rather not know some things than know absolutely everything, because there's no ways you can ever know absolutely everything. So thank you. And I'll just present one short video, which is post-refractive surgery calculations, and it's more about decision making. So it would be great to have all of your inputs as well and see what you would have done differently. I would like to acknowledge Dr. Lucy, who's really the guru of these kinds of cases, and I always go to her for help in these cases. So she helped me here as well. And it would be great to have your inputs and see what you would have done here as well. We all know that refractive surgery is as much, if not
Tushar, I think we cannot see your video, Tushar.
Yeah.
You can stop sharing and share it again, I guess.
Okay. I'll do that. Now you can?
Yes, you can go ahead.
Okay, perfect. We all know that refractive surgery is as much, if not more, about decision making than about the surgery itself. I'll be sharing two different case scenarios which made us think, and hope it will stimulate an interesting discussion and good learning for all of us. The first case scenario that I'll be presenting is called the mysterious bumps. This was a 45-year-old woman who had undergone corneal refractive surgery 15 years ago. And she now complains of headaches, which are associated with visual work, eye strain, and blurring of vision. Her refraction showed considerable anisometropia, and she's not willing for contact lenses. So we had to plan how to go ahead with recorrection for her in the right eye. When you look at the topography, this looks like an extremely good case for corneal laser vision correction by any of the methods available. But when you see her clinically, it's evident that there are multiple stromal opacities at the level of the anterior stroma, and these are in the visual axis as well. The anterior segment OCT as well demonstrates an irregular corneal surface at the level of the Bowman's layer, and this has been masked extremely well by the epithelium. Taking all of this into consideration, we decided to not touch this cornea and to proceed with the refractive lens exchange. There was, however, another challenge that awaited us. The keratometry values were quite different from the lens star and the pentacam, and consequently, the IOL power that we would get from them using the Barrett True-K method. This is also visible when using the ASCRS online calculator. So I decided to ignore the lens star and go with the holiday EKR map of the pentacam. Fortunately, we did hit the target and the patient was reading 6 parts uncorrected. This patient was extremely satisfied with her distance vision from this eye and the near vision from the other eye, which had a refractive error of -1 diopter. So the question that I would like to ask about this case is, what could have caused these irregularities? Why was the biometry so off? And would you plan a different approach than this? The next case that I'll be talking about is called shooting in the dark. So this was a 35-year-old woman who had undergone LASIK in 2008, has consistently been unhappy with wearing glasses, but now also has blurred vision with glasses since the last 6 months. So on examination, there is a myopic refractive error and has now developed a nucleus sclerosis grade 2 cataract as well. So choosing the procedure is absolutely not difficult here. What was surprising here, however, is that the optical biometer did not provide any measurements of keratometry. And when you look at the pentacam, what is really surprising here is how flat the cornea is. The keratometry values are close to 25 diopters in both the eyes. And even when you look at the holiday EKR report, you see an extremely flat cornea in both the eyes. Keratometry values of about 21, 22, 23 diopters in different zones. So then we went ahead to calculate the IOL power here and entered these values into the ASCRS online calculator, as we usually do in these cases. However, check the input instead. We then realized that the lowest acceptable keratometry values for the ASCRS online calculator is 31 diopters. So we decided to calculate the IOL power with that value, and what we got was about 16.5 diopters. Now we have a difficult situation here where we know that the cornea is much flatter than we've actually entered into the calculator. So the IOL power has to be higher than what we've got. So we decided to go with an IOL power of 21 diopters in the right eye. With that, we fell a little short and had a hyperopia of 1.5 diopters post-operatively. In the left eye, we decided to go for 23 diopters, almost hit the target, but still fell a little short and had a hyperopia of 0.5 diopters. So I would like to ask the panelists, is there a more accurate way to do this, and what could have been done differently here to get better outcomes? Thank you. So thank you. Thanks a lot.